Hello RB. It's a pleasure to present the Public Health Medicine Committee report for the 2020 ARM, albeit in a rather unfamiliar manner. PHMC represents public health doctors across the UK, and it's responsible for leading on the development of public health policy within the BMA. We have a subcommittee representing public health registrars and devolved nation committees in Wales and Northern Ireland. PHMC has, as is appropriate in a public health crisis, been very active in supporting the wider work of the BMA in relation to COVID-19. This slide lists some of what we've done, either as a committee on our own or in wider collaboration with other BMA officers and committees. While JDC negotiates on their behalf, there are some issues that are particular to public health registrars, especially in England. When COVID-19 struck, PHE fairly quickly agreed to pay for additional time worked on the COVID-19 response. We have, however, heard rumours that some registrars in English local authorities have been asked, perhaps with at least implied threats of detriment if they don't, to step up and work a lot of extra hours for no or minimal extra pay. We've been working to ensure that this does not happen. We remain very concerned about the position of doctors working in public health in English local authorities. The BMA is not a recognised trade union for contract negotiations in local authorities. Following the Lansley reforms, public health doctors in English primary care trusts were moved into these authorities where their terms and conditions were protected for 2 years. Since then, however, many have been moved to local authority terms, taking massive pay cuts and losing important contractual rights and the right to pay for additional work in the process. Others who remained on TUPE terms have not had the pay rises granted to doctors and the NHS passed on to them. This has led to an increase in the proportion of doctors in local authorities who are young or female. We have heard rumours of doctors being expected, sometimes allegedly bullied, to do unpaid work as a result of COVID-19, and we have been attempting to quantify this problem and to do something about it. The COVID-19 pandemic started after years of cuts to public health. Public Health England's budget was cut by 40% between 2012 and 2020, and local authority public health budgets in England were cut by 700 million in real terms between 2014 and 2019-20. The health of the public is based on the wider determinants of health. A decade of austerity has led to widening of the gaps between rich and poor. During the 2000s, the gap in life expectancy between the poorest 20% of areas and the rest narrowed. But during the decade from 2010 onwards, it has increased. The child poverty I mentioned last year hasn't gone away. Public spending has not just been cut, but it has been cut hardest where it is needed most. In the least deprived 20% of areas, local government spending went down by 16%. In the most deprived, it went down by twice as much, by 32%. Similarly, spending on adult social care was reduced by 3% in the least deprived 20% of local areas and by 16% in the most deprived. The double economic whammy of coronavirus and Brexit may well lead to further periods of austerity in which the poor are, again, squeezed particularly hard, compounding the harm done over the last decade. This may well play out in healthcare with increased rationing of expensive treatments. We must be ready to contribute to a public inquiry over COVID-19. Returning to the craft of public health, the divisions created by the Lansley reforms are sure to be revisited. On one level, this may be an opportunity to make things better, but particularly given the way the government has handed out contracts without tendering to private companies to sort out COVID-19, it suggests that maintaining a public health profession may be difficult. Governments submit to professional scrutiny from people who know better than they do reluctantly at the best of times. These are not the best of times. COVID-19 has meant that the Public Health Medicine Committee has had a crucial role in the BMA's policy development and communications. The possible ending of the first wave of COVID-19 does not mean that everything will go back to normal. There will be ongoing activity for at least 12 to 18 months. We will need to make good use of returners to public health and to recruit more specialist staff. Public health will need the support of the wider profession to protect their specialists from being blamed for the UK government's mistakes.